Good evening, everyone. How's everyone doing? Great. Fabulous location, isn't it? So, 8 years ago, we did a similar event in 2016 when we had the first high-level meeting at the UNGA. And, is that an alarm? And it was a great event too, and it was the first time that this issue of access to antibiotics was coming up at the United Nations. And I feel like in many ways, we've come a long way from there, but in some ways we haven't really come that far either. But we're delighted to have all of you here at this event to mark the kickoff to where we're going next in the next 4 days, which is a political declaration that I think and many feel makes huge improvements in what we had in 2016. 2016 was a placeholder. It was like putting down a marker for saying that antimicrobial resistance, everyone's right to have an effective antibiotic, is an important issue that deserves the attention of the United Nations. I think today we've got a declaration that makes steps forward in terms of some specified targets. It makes steps forward in terms of a monitoring mechanism, an independent panel similar to the IPCC to make sure that we're actually moving forward on things, to bring the best global evidence to bear on this. And I think we also have other aspects of the declaration, including on effluence, on the importance of the One Health approach, and very importantly, an issue which I feel is really important to a lot of people around the world, which is the issue of access to antibiotics. So it's not enough to have effective antibiotics unless people can have access to them. And in 2016, we had a Lancet series which pointed out that lack of access to antibiotics still kills more people than drug resistance does. And unfortunately, that is still the case today. So we need new antibiotics. We need existing antibiotics, but we need to make sure that all of these are made available to people who really need them. So on your way in, you might have seen this Lancet series, which just came out a couple of months ago, which is on sustainable access to antibiotics. And I think it points out that, and this is a number of authors, some of whom are in the audience from a number of countries, pointing out that we still need the access, we still need the new antibiotics, and we also need prevention. Prevention is very important. There are 7.7 million deaths every year from bacterial infections. Only a subset of those are because of drug-resistant infections. The remainder can either be prevented or they can be treated, and we don't really pay enough attention to that. So I think the organization of today's event follows that trajectory, which is first to question how we're communicating this. Do we have an image problem? Do people understand what antimicrobial resistance is? So we're going to talk about, whether those are the right words to use. We have the results of a new Gallup poll that's being released here today and a discussion after that. I think that the title of this itself is about sustainable access to effective antibiotics, which is really a much simpler thing than saying drug resistance. The second is really on the importance of prevention. We'll hear some of the results that came out in the Lancet series on 750,000 deaths each year that can be prevented if we invest in very simple things that every country already knows how to do. Water and sanitation, vaccination, infection prevention and control. And then the third is really on innovation and access. It is not innovation followed by access. It is innovation with access in mind at the time of innovation itself. And we've got some great panelists to discuss all of these three sets of issues. Of course, we're going to start with the beginning of where we're starting with the political declaration. And before that, I want to say thank you all so much for coming out here. I want to thank all of our co-hosts. I won't read out all the names, but I'm sure you'll agree this is nearly all of the very impressive organizations that work in this space, covering everything from drugs, diagnostics, infectious diseases, the whole bunch. And it certainly would not be an event that would be possible without the support and help of every one of these organizations. The event will be followed by a reception, which is just in the other room where you came from, except we will also have things a little more relaxing than coffee after the event. So please do stay behind, and there'll be hors d'oeuvres. So you can mingle after. We have this for another couple of hours. And the restrooms are straight down there where it says the exit, you move to the right, and then it's on the left. If you want fancier washrooms, they're on the left side, so you can ask around. So you want the common ones or the fancy ones. So I don't think we would have got here this far without some terrific leadership that we've had. We've had leadership, for the last quite a few years, on this issue, and a lot of it has come around, which has sort of spun off from this, the IACG, the consultative group that is set up by the 2016 declaration. And one of the bodies that emerged from that is the Global Leaders Group. And the Global Leaders Group, which has a few members that are also here, including Dame Sally Davies, but the chair of that group is Prime Minister Motley of Barbados. And I want to say that Prime Minister Motley has really led this with a significant amount of energy. The Global Leaders Group has come forward with positions that made it into the political declaration. It's not easy to get countries to just accept, ideas that just come forward. So I'd like to invite Her Excellency Prime Minister Motley for a conversation about the issue. Thank you. Yeah, you can sit here.
Thank you.
So, I have to start by saying, as a kid growing up in India, many of our gods in India, first of all, the religion of India is, does anyone know what the main religion of India is? It's cricket. And some of our big gods of cricket happen to be in this tiny island on the other side of the world. And I would have never thought that so many years later I'd get to sit down with the Prime Minister of Barbados, where people like Malcolm Marshall and Gary Sobers come from. And so it's a huge, huge honor for me to be here. But Prime Minister Motley, I think on this particular issue, you've seen this and the political declaration, which you, along with Malta, have really shepherded through the process. And you must be quite pleased with where it has come. It's made a lot of progress from where we had before. What are some of your thoughts on what this declaration achieves that make you really happy? What concerns would you have about what we haven't managed to accomplish?
I think that we are, first of all, let me thank you for the opportunity to share with you this afternoon and to say to you that we potentially can get off to the best start now, because you have already established why we are united at the hip, and it's called cricket. India just won the World Cup in the T20 in Barbados at the end of June. And
I didn't want to say that, so I'm glad you said it.
I say it for you since you spoke about the greatest cricketer the world has ever seen, our own national hero, Sir Gary Sobers. So we are on even ground now. With respect to the political declaration, look, the last time the world got together to discuss this was 2016. Almost 10 years has gone. I became involved back in 2020. I'm looking at Dame Sally, I think it was 2020, just as the pandemic broke out. And so much has happened since then that I sometimes have to reflect on the timelines. But suffice it to say that I remember about a decade ago watching a documentary that left me very, very unsettled about the impact of antimicrobial resistance. And therefore, when Dr. Tedros asked me to serve, I felt that I had a moral duty to serve. And one of the first things we discussed when I came on board was how do we mobilize people who really are going to be on the front line of the risk. What do I mean by that? That yes, there are already too many people dying, but if this is going to be the #1 killer of people by 2050, then we have a moral obligation to start now. And if we had 20 companies doing research on antibiotics in the year 2000, and we have 4 now, then we have a moral duty to be able to raise this issue to the highest possible level. In the meantime, what happened? The real fast pandemic happened and shut down the world. This is what, and I quote from the head of the FAO, this is a slow motion silent pandemic. And we have to get that in people's psyche. I believe that the political declaration that we settle on this week has the potential to be able to supersize it in terms of where people see it as a threat globally. I believe that the commitment to $100 million, which is absolutely modest and insufficient, is the beginning, however, of getting others to understand that fundraising is critical, not just to getting countries to prepare themselves with their national plans and to take the actions that are necessary, but it is also critical in sending a signal that we are going to have to be able to find a mechanism for funding something that effectively is not economic, but yet is critical, or doesn't have the level of financial returns, I should say, but yet is critical to the economic stability of the world. And what do I mean by that? We take antibiotics for how long? 7 days, 14 days? Pharmaceutical companies make their money from drugs that people take for years. And therefore the disparity between the economics of antibiotics and the economics of normal pharmaceuticals is something that is going to continue to challenge us. I think that this political declaration does first and foremost us the benefit of raising its awareness among the political class, but equally the international financial institutions who are going to be absolutely critical, not in agreeing to what we agreed to this week, but in really doing the heavy lifting to carry us much further ahead than where we are. The fact that CNN and others quoted the Lancet article, was it last week, I think, was also of benefit because people sometimes need a wake-up call. And I therefore feel that this political declaration carries us in these areas. There are detailed plans with respect to what is required of us politically, but equally what is required in terms of public education and what is required in terms of research and all of those other things. So, and of course you have the two people who did the heavy lifting in front of us, my own ambassador and the ambassador from Malta, who you will get a chance to listen to, I believe, this afternoon, but they're the ones who've done the heavy lifting that have allowed us to be here this week.
No, they absolutely have. So one of the major recommendations of the political declaration is to invite the quadripartite to set up an independent panel which would be able to bring the best evidence, be able to monitor progress in simple words, just to keep the fire burning under this issue, while the UN is done with this job and keep it going, beyond. And this has been done by academics before, but this is really to give it a much more of an organized process in the same way that the IPCC does for climate, but there are other bodies like this that do it. One of the issues that is of concern to many of the LMICs is really on how to maintain true independence, impartiality, and effectiveness in this, and we conceive this as an independent panel, not an intergovernmental panel. How do we make sure that that happens?
By doing it. We have to agree to it, and we have to let it work. If it wasn't for the IPCC, we would not have the truth on climate today. We would not know that we have hit 1.5 degrees already, even if not sustained that temperature increase. The reality is that we need some entity that can be a North Pole with respect to speaking truth so that the public is aware of it. And why? We live in a world with too much fake news. We live in a world with too much agendas. We live in a world with too much lack of trust. And when you combine all three of those things, it is a no-brainer that we have a scientific panel to deal with medical and scientific evidence to tell us the truth about what is happening. Can you imagine if the lobbyists from the agro-industrial sectors are allowed to just be able to tell you what they need for profits, but they don't get to be held to account for the level of antibiotics that they're putting in this livestock and the consequences of it to people? Everybody in this room, I am sure, knows a few people who have died as a result of the inability of the antibiotics to be effective in treating people. Everybody. And it is so commonplace that we run the risk of being desensitized by it. So I really feel that the ability to have an independent panel that is only concerned with the evidence and who speaks truth to power. They're not into the lobbying, they're not into the politics, they're not into anything else. They just tell us the evidence.
Excellent. Well, we certainly would hope, and I'm sure many people in this room would love to see an independent panel happen, much sooner, and and as soon as it can be stood up and start putting out reports.
I think the fact that we have a quadripartite approach with WHO, with the United Nations Environmental Programme, with FAO, Food and Agricultural Organization, and with the livestock entity OIE, makes it easier because those four themselves, no one can take dominance over the other, and therefore you need to be able to have an independent entity that can put the facts out there without the risk of any rose-colored lenses.
Absolutely. So you spoke about funding, which is something which is not explicitly dealt with in the declaration because it can't be, but it's going to determine a lot of what happens. Fortunately, I don't think the price tag for dealing with this issue is anywhere close to what we had to spend for HIV, for instance. But that said, all of our evidence shows that we're spending probably about 10% compared to HIV if you just compare burden on an apples to apples kind of a basis. How can we really motivate better financing of this issue beyond just a couple of countries stepping forward to take leadership? This will really have to take many countries coming together. I think some of this you have in the the Bridgetown initiative, which is really to also make sure that there's LMICs have the wherewithal to tackle these kinds of challenges, climate particularly there. But how can we bring LMICs that need this help in the case of AMR to also receive the resources that they need?
I'm not sure you want me to answer that fully because I'm going to have to answer it by telling you by not having a siloed approach. Look, we're in New York this week discussing the Summit of the Future. And whether it is AMR, whether it is climate, whether it is fragility and conflict from war or from simply too high a homicide rate as it is in the Americas, whether it is water scarcity or food scarcity, whether it is digital divide that has led to greater social implosion, we are facing a number of global problems, any one of which can take us out as a civilization, and any one of which will compromise the level of growth as we go forward. I'm not a doctor, but I would like to believe that if I went to the doctor with a pain, that they're not only going to identify where the pain is, but they're going to want to give me a holistic treatment. So from where I stand and from where the Bridgetown Initiative stands, the holistic treatment has to be a different financing mechanism for the establishment of the global commons. AMR, the slow motion silent pandemic, is a critical part of working, or let me put it another way, we have to ensure that we can work to prevent the pandemics, whether they're fast or slow, that we can work to literally constrain the extent to which the climate crisis is going to put people and planet at risk, constrain the extent to which war and conflict will continue to cause people to lose their lives and to be dislocated, continue to ensure that we can do the immediate, because people can't do without water and can't do without food for a long time. So here's the deal. If we form the World Bank in the third decade of the 21st century instead of forming it 80 years ago, would we have only been focused on infrastructure and the relief of poverty, or would we also have been looking, as we must today, at the establishment of global public goods being protected and the establishment of a global commons? To that extent, therefore, what is the principle that I want to see be able to inform? The reform of the bank, to be able to let it be the trustee, the guardian of the global commons and the guardian of global public goods. You will say, correctly, that there's not enough public money to be able to ensure of that, especially since many of the G7 countries are themselves under notice from the IMF and others as to the fiscal imbalances that are threatening their own stability. That's cool. So how many multinational corporations do we have in 2024 as compared to 80 years ago? And what are they doing and making their money from? We have a simple principle that we have used in the international arena for some time, the polluter pays principle. That really just says that if you're responsible, you pay. But I go further. There are also those who will benefit egregiously and have a rate of return that is far in excess of what might otherwise be acceptable in good and polite company. And to that extent, they too should also be asked to contribute. And what are we talking about? A sum that would bankrupt any of them? Absolutely not. But if you take 3 to 5 cents out of every dollar and say that we got to put this one side to be able to finance the solutions necessary to keep the global commons in good shape, then you immediately take the pressure off of the G7 countries who are complaining, although not with proper cause. And 2, you immediately create a platform that is sustainable, because I use it with climate all the time. Global shipping generates $7 trillion a year. If we were to take 1% of that, that's $70 billion of contribution on an annual basis. So let's deal with pharmaceutical companies now. Pharmaceutical companies make extraordinary profits. Yes, they also take extraordinary risk with research. But if we found a mechanism where their profits, 2 cents, 1 cent, of every profit they make can go to ensure that there is research for this thing that can threaten human existence, then we have the assurance that they're not only going to make decisions based on the financial returns of the products that they're researching. So I feel strongly that we need a completely different approach that is joined up, because the world is not facing one issue as we speak. The world is facing multiple issues. And I believe that the principles are simple, they're transparent. If you help cause the problem, or you will benefit egregiously from the solution, leave 1, 2, 3 cents, 4 cents, 5 cents on the table in every dollar. If I were to buy, and maybe the metaphor is not the right one, but I'll use it nevertheless. If I were to buy a chocolate bar, and you asked me for 2, 3, 4, 5% of the chocolate bar, it is so small that I'll probably offer you another 10% of it. Greed determines that would be the only reason that I would not want to share it with you. And I think that unless those who own the shares or benefit as managers in the pharmaceutical companies, like the ones in oil and gas, know of another planet to live on, or know of another way to sustain human civilization, if I were them, I would have a win-win perspective and believe that if something is going to be as devastating as AMR will be to human population, if we're going to reverse a century of medical progress, and as something as simple as going to the doctor or going in the garden and getting, as we would say in Barbados, a juk, can now put you at risk, then we all have a collective responsibility to get this right. And the other one that we're not talking about at all is the yield from our soils. Our soils are showing declining for yields, but yet nobody's doing the work necessary. If you continue at this rate, how are you going to feed the people, the population that they say will be almost 10 billion by the end of the century? How are we going to feed them? So I really feel that the world needs to pause and get a few things right. And AMR is one of those things that must be at the center of it.
Absolutely, couldn't agree more. So last point is really around what your aspirations are as the head of the Global Leaders Group in, say, 5 years from now. What would success look like? Or what situation could we be in that you feel, oh, we just didn't make all the progress that we put all this effort into creating this political declaration, but we didn't get anywhere? What
I
would
think
that look
a
like?
number of things. Obviously, we want to reduce the number of deaths. So that the declaration sets the target of the reduction of deaths by at least 10% by 2030. We want to reduce the extent to which antibiotics is used in the livestock sector and also with the use of plants. That is a case of re-education. and also ensuring that we may have to do some regulations country by country by country. And sometimes you can't leave things to the will of people. If we have a globally enforceable agreement on methane, that would help us significantly in mitigating against the climate increases. We have a voluntary agreement, so we're still at risk. If we have regulations with respect to what firms should be able to use with respect to the raising of livestock and the agricultural practices that they have, that will help. But there's one thing that I would like to see even more, because that is going to carry us beyond the 10%, and it's going to carry us beyond the agricultural thing, is for us to start teaching children in primary schools and secondary schools about the dangers of this. Because people, without thinking about it, just go and do things. They start taking the antibiotics because the doctor gave it to them, even if it is not necessarily the best way to deal with an issue. And then invariably, and I'm guilty of it too, you don't take the full course until you begin to understand the consequences of not doing these things. So instead of us only dealing with high matters of state and war, etc., let's deal with the things that are necessary for behavioral change. HIV and AIDS turned the corner when effectively almost every citizen on earth could speak about it in a credible way. We need to be able to have the level of public education so that human beings, more often than not, if given that same information, they will act in a manner that protects themselves and those around them. So, and I could go into a lot more things, but I'll stop at those three.
Okay. Well, thank you, Prime Minister Motley, for your leadership, for being here. I know you've got a very busy schedule in New York. Ladies and gentlemen, please join me in thanking Prime Minister Motley.
Thank you, and I want to also say that those who have been working in the vineyards, like Dame Sally and others, for decades, are the ones who really have now to be saluted. And as I said, ambassadors who have brought us to the stage where the heads of government can give true expression to what we're talking about this week, I want to thank them as well. Thank you.
So I'd now like to invite Ambassadors Jackman and Fraser. Yeah, you can sit in. So as the Prime Minister said, the two people and their teams who've been doing all of this heavy lifting to herd cats, which is probably herding cats is easier than what you've done, to be honest, to get us to this place, which is a declaration which obviously is not going to satisfy everyone, but in some sense, if everyone's not satisfied with it, it means that you've got somewhere good, because it's not like someone got extremely satisfied with it, which would be a problem. So it's been a long journey to get to this political declaration. In what ways do you think it improves on what we had in 2016? So, Ambassador Fraser.
Thank you. First of all, thank you for today. And it's very difficult to speak after Prime Minister Motley, because she was very much our inspiration whilst we were working on this. And as you said, I was talking to some people earlier in the reception beforehand. Everybody was sufficiently unhappy, so it means we had a balanced text, so that is good. But 2016 was definitely the foundation that we built on, right? However, this declaration has a more targeted approach rather than which was not the case in 2016. We immediately, when we set out, we had said that we wanted to have an ambitious declaration which would have measurable targets. And I think that was one of the differences and one of the achievements that we had. And also the One Health approach is something which is concrete in this declaration and differs from 2016. And the involvement of the quadripartite, certainly. I don't know if you have maybe anything more to add onto this, but those are the major differences that I see.
I would add, as Prime Minister Motley said, and again, thanks for the invitation, Lex, and thank you all for being here. I think the success we hope we have achieved in crystallizing the panel will have a very powerful effect and really marks a change from where we were before. And along with the points that Vanessa has raised and those raised by my Prime Minister, I think those are some clear differences and advances vis-a-vis 2016.
So your teams have been working on this for a long time, and I've had the pleasure and opportunity to watch from up close this entire process, because I know how painful it has been at every stage. We've been through many drafts and many sticking points, all the way from just from the very beginning, understanding whether we put in One Health and so forth. But a lot of folks here who work on this issue would love to hear what were some of the easier things for countries to agree on without giving away names of countries, and what were some of the more difficult things for countries to agree on? Ambassador Jackman, do you want to start? I mean, you may have a very long list, but maybe the top 3 or 4.
We are diplomats, so we wouldn't have a long list.
We don't have all night, no. Actually, to be fair, I would say that from the beginning, what was clear was that across the major issues, and I think this came in part from very strong signaling from the AMR community itself. Across the major issues, there was a broad consensus. There was an understanding on the part of member states that were invested in this process, that we really needed to move beyond what we'd agreed to in 2016, and that looked like targets, it looked like some sort of an institutional mechanism for science. It looked like some strengthening for the UN's own institutional architecture. So I think on the big ideas behind this, and again, I must pay tribute to the community here and beyond that really popularized, proselytized around these ideas. I think member states knew that these were the kinds of things we had to get some form of agreement on. And then lots of other things intruded, some of them immediately relevant and of concern, and Prime Minister Motley mentioned finance, and that's a particularly interesting issue where we have a result which I think is encouraging. And then some issues which are frankly seemed on the face of it at the very least to be not related to AMR but related to the larger context, the larger geopolitical context.
So Ambassador Fraser, you're also on the Security Council, which probably takes up a little bit of your time. We obviously have AMR, which is a big issue, but there's also Ukraine and Gaza and everything else. How has sort of the environment for these kinds of declarations changed in terms of just getting countries to agree on a particular topic? Because many of the issues are not specific to just AMR. They're for everything. They're for pandemics, whether the world agrees on universal health coverage. What are some of the challenges you're seeing? So this is just to build on what Ambassador Jackman also spoke about.
I absolutely agree with everything Anne-Françoise said. The great thing was that when we started, there was a consensus that there was a need for this work that we're going to do. So we started from a very good footing. And then, of course, the devil really is in the detail. But there are the greater geopolitical issues, which are also, which found themselves in this text. And as everybody knows, we have, for example, our final text, which we hope will be adopted on Thursday, has some language which was removed from our first draft, our earlier drafts, which were nothing really to do specifically with AMR, but for example, the sanctions there, right? So we know that when we were dealing with this, there are some countries that have, and rightfully so, because of their own experiences, there is a principled position that countries take on certain political issues, geopolitical issues. But, and we had to consider this, and when we realized that they were not specific to AMR, but it is a bigger picture, we're able to find consensus on it. So you mentioned the Security Council, you know, people always tell me, oh, it's such a difficult time to be on the council because it is so divided. But we get work done. We have gotten work done. There is a way to find consensus. We have been on the council for almost 2 years. Resolutions have been adopted, and work has been done. The implementation is the issue, and we hope that this resolution, this declaration definitely will be implemented, and we see that there is a goodwill for it.
Excellent. Well, you know, certainly the declaration is something which, as you mentioned, those elements are something that we're very, you know, pleased about. What were some of the lessons for you? I mean, I remember the very beginning conversations when, you know, on this, which is, there was a certain amount of an educational process because neither of you was familiar with AMR per se, so you were coming up to speed on this entire thing. What are some of the lessons for you on negotiating this that we can all collectively learn from in terms of what flies? What is the UN good at doing that if we can bring some of these topics here? And you know, what are the things that we shouldn't be expecting out of the UN on a declaration like this? Jack, Ambassador Jackman, do you want?
Well, I'd leave that to you.
You know, I think this is exactly the type of policy where the UN should have a voice because there is a global need for it. Every country that was party to this negotiation knew that you know, the global health bill was going to be increasing if we do not tackle this, that the life expectancy was going to be reduced by 1.8 years. And so everybody knew these statistics are there and governments understood it. So it's not something, you know, AMR is not something which is a challenge just to a region or to a group of countries or to lesser developed countries or to island states. But it's really every single country in the world, every single member state has a stake in this. And so it is exactly where the UN should have a voice and should have a policy.
And if I may add, I would say that the UN is getting better at, but it's still not great at hearing the voices beyond the governments, voices like yours. But we did benefit from hearing these voices, whether it was from industry, whether it was from survivors, whether it was from institutions doing research or philanthropic institutions. We did hear them. They echoed both formally through the multi-stakeholder process, through the GLG, and through the many conversations that we have had and our teams have had with many of you and many of your colleagues. And I would say that is really also going to be an important part of the follow-up, which is certainly don't leave it to the UN just to do all the follow-up of that political declaration. I mean, you know this. You all of your communities, your expertise, your institutions have to keep pushing to make sure that what we have in this text is truly brought to life, that we have the opportunity to review it, I think in the 81st session, and the opportunity to have a really important third bite at this cherry in 2029. So the role of, I mean, obviously governments are the key players in the intergovernmental process, but the role of the non-governmental part of it is absolutely essential.
If I may add to that, we really did make ourselves available to everybody who asked to speak to us, because we did learn so much from this process, and we learned very much from all the stakeholders, and we tried to have a very transparent process where we felt everybody and all the stakeholders were included and felt some ownership. And we did ask for help, lobby on this, speak to governments on that. Yeah. You know, because we all want to move forward together, so we felt the stakeholders were part of this with us.
No, I have to agree. As one of those stakeholders, it was a very effective process. Your listening was very good. I think your teams here were right here who actually did a lot of the work here, were always available for us to provide that input and feedback on the drafts. And I think it really helped get a lot of science into the declaration. There might have been concerns that it's too long, but sometimes that just happens when you have a lot of viewpoints needing to be reflected there, then it's all sort of...
We dreamt of a two-pager.
Yes, I remember.
Two pages.
Yeah, it's only about 2 and a 0 after that. So, It's all right. So, in conclusion, what advice would you have for the either too fortunate or unfortunate souls who have to shepherd this in 2029, given that you folks will be gone, but many of us will still be here dealing with this issue? What would you have done differently? I mean, it's always good to reflect and say, here are things that we could have done from the start, and is there anything at all that you might do differently and perhaps not?
First of all, I think we had really good teams. I have to say, shout out to our people,
Yes.
Our teams, really, they're here. It was very, very important. Our governments, because our, Prime Minister Motley and our Deputy Prime Minister were the President and Vice President of the Global Leaders Group. We had a lot, the only thing that I don't know if we could have really done anything differently, because we really tried to give as much time as we could and to speak to as many people and make ourselves accessible. And I think that is very important for whoever takes us over after us. And to try to build, always build. We always have to be moving forward. But we would have liked this to be more ambitious, of course. We would have liked for our first draft to be adopted, clearly. But we're very proud of what we have. And what's important is that it is, these are building blocks and they don't go back, but move forward.
Absolutely. Ambassador Jacqueline?
I don't think I can add much to that. We have certainly learned a lot about AMR, and I think Prime Minister Motley made it clear that from the perspective of a political leader, this is one issue in a universe of issues related to public health, to development, to resilience. And I think it's important to see it in that way, even as we zero in on the measures to tackle this specific problem. And I hope that that comes out in the political declaration. And I hope that in the follow-up, and really I have a great deal of hope placed in the financial targets, in the way in which we have pointed at institutions to say, you really need to do these things if we're going to get this right. If we could have pointed to them more pointedly, if we could have had more ambitious targets, that would have been great. The reality is when you negotiate with 193 countries, which have such extraordinarily variegated desires, levels of understanding, abilities to respond to the issues, you will inevitably end up with a result, as we said at the beginning, with which not everyone is, we hope, equally unhappy, but which has something for all. And I guess that's what we would salvage in our thinking about this for the future.
No, again, I want, on behalf of everyone here working on this issue, really want to thank both of you. Want to thank Melissa and Carl as well. You guys have put in a lot of work into making this happen. So thank you to both of you, and we look forward to seeing this adopted on Thursday.
Us too. Thank you.
Thank you so much.
Thank you.
So with that, I hand over to the second panel. The panel will be moderated by Apurva Mandavilli from the New York Times, and I would like to invite the presenter, Ilana. Oh, you're right here, Ilana. Okay, why don't you go first, and then the panel can come up.
Thank you. Thank you so much. It's wonderful to be here. Hopefully our slides will come up, and we're very excited to present some new and emerging research about the global AMR monitor. Okay, let me go back. So everyone in this room knows that knowledge about AMR is really critical to reducing its burden, but there's limited global data. All of the global strategies about increasing AMR knowledge and national action plans really call for increases in knowledge, but the lack of global data that's consistent, that's comparable across countries, makes this knowledge really difficult to track. So what we are proposing in partnership with our partners CDC Foundation and CDC is a new data resource called the Global AMR Monitor that's really going to drive sustained attention from all the different constituencies that matter to the fight to combat AMR. What we've been able to already conduct, and thank you for the funding provided by Cencora Impact Foundation and Teva Pharmaceuticals, is some formative qualitative research about awareness of AMR, knowledge of AMR, behaviors about AMR in 3 countries, the US, South Africa, and India. In the United States, we did focus groups with the general public, and in India and South Africa, we were able to interview qualitatively those practitioners at the forefront of AMR. What we're hoping to do is to launch the Global AMR Monitor through the Gallup World Poll, which is the world's largest survey of human development, which is conducted in 140 countries annually. We want to use this data to ensure that knowledge is increasing, behaviors are changing, and that we have a pulse on whether or not strategies to increase knowledge and awareness are really taking hold in the population. So let me tell you, though, about some of these really interesting themes coming out of the phase 1 research. In general, there's varying levels of AMR knowledge and concern, and we'll unpack all of these in a moment. But even when there is knowledge of the risks of AMR, we're really seeing a lack of consistency in actions, both in terms of the public in the United States and practitioners in India and South Africa. And there's a lack of understanding, even among those professionals who you would expect would have the most robust knowledge about the relationship of the use of antibiotics and the emergence of AMR. So let's get into each theme, and we really wanted to bring you a lot of quotes of the voices of people across the world and how they're thinking and feeling about AMR. In general, there's varying levels of knowledge and concern about AMR. But when we looked across everyone that we qualitatively interviewed and spoke with, it's really congregated in the low and moderate concern, with few in the high concern. Wanted to draw attention to a farmer in India who is really, I think, illustrative of what we heard from so many, who said, no, there's no real danger because once the medication is given, the animals recover. It's very rare the medicine won't work. So I think that's a good example of that combination of low knowledge leading to low concern. But even when there's knowledge of the risks of AMR, we really saw a lack of consistency in actions regarding the appropriate use of antibiotics. And we were able to classify some of those reasons that we saw across our interviews why antibiotic best practices weren't always followed. So things like prescribing without testing, sharing medicine, which was a very surprising and important finding. You know, it's common for families to share their leftover antibiotics. It's a way to show you care. Or no prescription at all. And finally, this lack of understanding, even among professionals, again, those who should really most likely to understand the risks associated with antibiotic use leading to AMR. We saw a whole host of different types of lack of understanding. I think what we wanted to call out, though, was that it was a pretty pervasive sentiment for the doctors and veterinarians that we spoke to in India and South Africa who felt pressured by patients or by others in their ecosystem to prescribe antibiotics. Patients walk in and tell us that they have the flu and they need antibiotics. As doctors, we end up acting out of pressure when our clients ask for antibiotics, and we end up giving it to them. So just to conclude, we wanted to really make the case that measuring and increasing AMR knowledge globally, it's vital in the fight against AMR. This research shows that there's low, across our key audiences and countries, awareness and understanding of AMR, and there's variation in certain of the findings by country, so country context matters. We're really hopeful that the Global AMR Monitor will launch and close really a critical data gap and strengthen all of our efforts to both improve AMR knowledge, but most importantly, really track whether our policies, our programs, our industry best practices are making a difference globally. So if you're interested in joining this fight with us, please reach out to our partners at the CDC Foundation. Thank you.
Thanks, Ilana. Wanted to introduce Poonam Mandavali, who will be moderating this panel from the New York Times, Michael Craig from US CDC, and Gada Zubair from ICARS.
Hello.
Hello.
So that was a very interesting set of results. I'd like to ask both of you, actually, what you thought was the most important takeaway. And part two to the question is, what were you most surprised by, if you were, and why?
Okay. Before we get started, I do want to reiterate the thanks to the Cencora Impact Foundation and Teva Pharmaceuticals, who we would not have the data that we just presented without that support. I think the thing that struck me or most surprised me is the commonality. There is so much lack of understanding across countries. There were 3 very different countries in 3 very different places there, and yet we saw the same patterns of lack of understanding, awareness, and engagement. And I think when we think about what we could do with improved data, having data from 140 countries as the global AMR monitor aspires to do, we could really change that fundamentally. We are here this week setting apart and setting time to make agreements and commitments globally across all of our countries. But we're not going to be able to succeed in achieving those commitments if people don't understand the problem to begin with. And so when we think of the global AMR monitor collecting data across 140 countries so that we know what those knowledge, attitudes, and beliefs are, that can help us drive better policy. It can help us drive better awareness. It can help us drive better programs. So ultimately, I see it as our work on considering awareness and how do we address it is often an afterthought, and we need to make it a forethought.
So looking at the slides, thank you very much for the invitation to take a comment on this panel. And for those who don't know ICARS, we work with low middle income country in partnership to mitigate AMR. So we have been exposed over the last 4 or 5 years to some of these issues that have been highlighted in the presentation. But what really strikes me here is we're still trying maybe to oversimplify antimicrobial resistance and the way we might be able to understand what it is. See, it's a big umbrella that covers so many infectious diseases and so many conditions. And sometimes maybe a survey needs to be a little bit more nuanced to be able to capture that. We're talking human, animal, environment. We're talking so many infectious diseases, so many pathogens, and so many consequences. If we start with the antimicrobial resistance as a term, and sometimes we use it because we're lazy as AMR, amongst our friends and colleagues, that doesn't translate very well into too many languages. And there are people in this world who don't speak English, to surprise some of you. And if you translate it into Arabic, it's a sentence. I had to translate it to my mother, who's a highly educated professional. It's a whole sentence that explains the fact that this is the pathogen that becomes resistant, and the infection and the antibiotic cannot really kill it. This is a mouthful. So you get to a stage where you want to do a survey. How do you actually position and explain that term so that you can get the best out of the survey, whether you're dealing with a farmer or a clinician or a teacher or actually a child? Really, you need to probably have more of a mouthful than antimicrobial resistance. So this is the first impression, that it just reminded me of how complex the issue is and how we need to dig deep in how we capture awareness within different countries.
It's interesting you brought that up because, as a journalist, I have a lot of Google alerts, and I have one for AMR, and 90% of the things that come through that are for this company called American Medical Response. It's an ambulance service company. So it does seem like there might be room for some rebranding of AMR, especially it seems like with the new declaration. So what would you do with the information that you just got from here? One of the responses in there was, you want this. Resistance is a good thing.
Right.
So clearly there's a pivot that's required. So how do you go about changing the way people think about this?
So I think part of what we've talked about this as a community. This group of people, I've had these conversations with folks in here going on many years, and we've argued about antibiotic resistance, antimicrobial resistance, drug resistance. How can we come up with the best terminology? And I think we're not ever probably going to get to 100% consensus on that, but I think we have to start somewhere. And I think what we're trying to do with the monitor is start to get to a level of data. I think Gada brings up a great point that this doesn't translate well. But we're not ever going to figure out how it translates better if we don't start collecting data in the first place. And so starting to collect that data and getting an understanding of what people understand and what they don't understand, I think will help us refine that as we go, help us refine the survey questions, help us refine that as we evolve. I think the really interesting thing would be to see data from 140 countries about what people do understand and what they don't. Because I think we all agree that there's low understanding. But it may not be universally low. It may not be universally low about all aspects of antimicrobial resistance. I also think we can use this to engage policymakers. If we ask survey questions that get at and help people understand, are you concerned with untreatable infections? And if we get numbers, I think we're going to get numbers where people are concerned about that. And you can take that to a policymaker and say, 70 to 80% of your constituents are concerned about this. What are you going to do about it? We can take some of this and we can raise awareness about what is going on so that when we go to implement a program, when we go to give someone a vaccine, or when we go to do something else, they understand why they need to take it and why it matters, right? We can't tell people continually to stop using an antibiotic when they think antibiotics do no harm and only help them.
I'm less enthusiastic about rebranding, all right? We can keep on rebranding and we'll still get probably some same answers. I think, again, going back to framing the problem, to who is the audience you're talking to. Mm-hmm. When we are talking about animal health in country X, which we have been working with, the farmer cares about the herd health, the herd management, the fact their livelihood will not be impacted by that infection that he or she cannot treat. When you're looking at urinary tract infection in some women in certain country as well, those who are the end user, the impacted one, the community one, are the one that actually going to be framing it. You can call it antimicrobial resistant in high-level document, but when it comes to actually working with finding solution, you really will need to name it. It could be sepsis, it could be UTI, it could be respiratory infection, it could be cholera, it could be TB. It's a wide range. We are, as a community, lazy by using that term, but we have to start somewhere. I'm not suggesting to change it. And some organization as well showed and offered other alternatives. But I'm suggesting that when you are framing that antimicrobial resistance with the idea that you are collecting data for action, and CDC has mentioned that again, you're not collecting it just to see what people know, because the farmer that here showed that they may not know, I would argue that there are farmers who understand. So it depends who you interview and what you end up with, qualitative, quantitative data, etc. But of course, there need to be some socialization of the problem with the idea, what are you going to do about it? Mm-hmm. Just because you have raised awareness does not necessarily mean that you're going to change behavior. Otherwise, I would have stopped eating chocolate. Otherwise, a lot of people would have stopped smoking. Just because you know what's bad for you doesn't necessarily mean you're going to act upon it. It will be a multitude of intervention that will come together, whether it is education, whether it is incentivization or penalization, regulation. So you need to look at what you're looking for and what are the different perspectives. And I think I go back again to what we're doing at ICARS. We're learning a lot in the last 4 years. We're in over 20 countries, 40 projects. We're learning what works, but more importantly, what doesn't work. Because just because we think scientifically, that makes sense. But when you go on the ground, there's a lot of cultural, social, economic aspect that will not make you progress with where you want to go with this. So the data is welcomed. It's a great starting point. It will be nice to align it to some of the data tracks that is capturing. I was looking interestingly about what is the US doing, just to compare it to the data. And of course, they have awareness raising programs. So, and there's still some who are not really aware of it. So just because you have awareness raising campaign doesn't necessarily mean that you're gonna have everybody aware of it. And I think we just need to reframe some of the terminology so that the next Gallup survey will take all of these nuances into consideration and work with others who are already as well capturing some of that data, whether it's scientifically or WHO and other organizations.
Well, you mentioned that you might be able to take to the policymakers that 70% of people are interested.
Right.
And I know you were giving an example, but it's hard for me to imagine that 70% of people think about it at all or care about it enough that you could say that to a policymaker. So part of what I want to ask you is how do you think about this in the context of post-COVID, when people are actually quite anti-science, anti-medicine even, don't think about medicines as their friends or that it's something good. So how do you shift that thinking?
So I think that's the thing is that when we talk about antimicrobial resistance, and I think Gada got this right, we don't often reach people where they're at. And we have to figure out how to reach people where they're at. Because I think if we do talk to people and we say, you know, have you ever had a urinary tract infection? Has your child ever had an infection? And then give them a hypothetical of what if we couldn't treat that? What do you think about that? Do you think we need to start addressing that? I think it starts to really reach them in a way that they might not appreciate before. And I think, as Gada is getting at, we have to be able to tailor these messages to different audiences. And I think what we see with the monitor is you can't tailor a message when you don't have any data to start with. If we're talking about looking at data for antimicrobial resistance, we would start looking at the data first and then figuring out where the data needs to take us for our next steps. We have no universal data, no global data of this scope for knowledge, awareness, and beliefs. And I agree, it's going to take time, but I think we have to be able to start somewhere, see what the data shows, and then tailor our interventions. And our interventions could very well be things like ICARS is already doing. It could be awareness campaigns. It could be a whole host of things, depending upon which audience we want to tailor it to. If a country finds that there's good awareness in a certain population, but bad awareness, say, in their pharmacist community, then how do they pivot that and engage those pharmacists and come up with an intervention that works? And it could be an awareness intervention, it could be a penalization intervention, it could be a variety of things. But we're not going to know which way to go or where to go if we don't have the data to begin with.
Just to add, and I actually agree, you need to start somewhere, and I think there is some data that is dispersed that could be as well great to bring it up with what the Gallup survey will do. But there is nothing as well like lived-in experience. Patients who have been through an infection that could not be treated. I was listening to a lady sharing her experience of having resistance urinary tract infection. She's my age. Her life changed. She can't go to work. Her husband can't go on holiday because he has to stay with her. I found myself, after working in AMR for over 12 years, I'm just crying in the middle of that audience, and I'm thinking, like, this is what you need to see. You need to see those who are actually living that or caring for someone who is affected. You should be listening as well to a farmer that has lost his livelihood because of an infection that couldn't be treated, and we can move on. And in addition to this, I was really inspired by Prime Minister Motley, who was mentioning education at school. There's nothing, if you ever have a child, there's nothing like telling a child something. If you want to change your mind, they'll remind you. Mommy, you have said that. Why did you change your mind? Mommy, you should be coughing in your elbow. Why did you not? You just give them that and they run with it. And I think there is a lot that we can learn from a range of a generation. And I know that here we're saying 18 plus, but I hope as well in the future with more support, it can be expanded to reach out to schools and other community, where those are the ones that are the future, looking at how we mitigate AMR.
Okay. Well, thank you both very much. I believe we're out of time.
I'd like to invite Professor Joe Luner to talk about some of the results of work that he's done on preventing infections before they happen. Joe, you can come up here. So, if the slides are ready to come up.
Thank you, and thank you for the invitation to share this work. At this meeting, a handout has been available of a series of articles in The Lancet which addressed the burden of antimicrobial resistance as it currently stands, as well as strategies that may be on the table for preventing it with existing tools. Many of the challenges with AMR surround infections for which we do not yet have viable drugs to treat infections that are resistant to what's currently available, and also strategies to change behaviors around prescribing and patient expectations to receive antimicrobial drugs. However, there's a lot on the table that can take apart the burden of AMR, centering on strategies that we already use to address the overwhelming and unnecessary burden of bacterial disease deaths that occur globally in both high and low-income countries. So we've established, first looking at interventions for which there are existing policy commitments and existing goals, what can be achieved through implementing throughout healthcare facilities around the world better standards of infection prevention and control measures, including essential things we take for granted like hand washing. We also consider what can be achieved if we deliver on Sustainable Development Goal 6, a pre-existing commitment to provide high-quality water, sanitation, and hygiene infrastructure to all people throughout all countries. And last, we consider what can be achieved through attaining universal access to vaccines for essential pediatric immunization programs throughout the world. The first of these is the consideration around delivering better access to infection prevention in healthcare facilities, starting with a consideration that as we look towards settings with the lowest GDP per capita, where the highest burden of resistance occurs, we have some of the lowest access to and implementation of infection prevention and control, which puts patients at risk for acquiring infections when they receive healthcare in healthcare facilities, many of which are difficult to treat or impossible to treat in the settings where these occur. This intervention alone could deliver an 8% reduction in deaths associated with antimicrobial resistance if we attain pre-existing commitments to deliver better on this measure. The second two classes of interventions that I talked about were those that address infections that occur in the community, specifically preventing infections, including those with resistant pathogens, through improved implementation of water, sanitation, and hygiene infrastructure, which has the additional benefit of reducing the occurrence of infections for which the greatest amount of antibiotic use occurs. And then in addition, we must consider better delivery of immunizations, which again can prevent resistant infections as well as drug-susceptible infections, but importantly, deliver a viable way of reducing the demand for antibiotics. Since we know that prescriber awareness, patient awareness, community awareness is low, there's an essential strategy of reducing the infections that cause antibiotic use to begin with. AMR reduction is a small component of the net health benefits of these interventions, which are already the subject of great priority, and suggest that we have effective tools to begin addressing a very complex problem that to date we have done too little about. Thank you.
I'd like to invite Dr. Sanya Nishtar and Dr. Sarah Dupre up for a discussion on this. Well, thank you both for joining us today. And as you can see, the prevention message is really important for AMR, but also makes it very strongly into the political declaration. I think with all these specific numbers, these numbers are in the declaration, but it really calls for prevention and specifically calls out Gavi to act. So how is Gavi thinking about AMR? You've now been in this role as CEO for about 6 months now. How are you thinking about AMR and what you can do to tackle this? And what are some of the biggest areas of opportunity for Gavi in sort of joining the fight against AMR?
Well, first of all, I must congratulate you and commend you for your relentless focus on this area. You clearly are a global champion, and I don't mean to embarrass you, but honestly, we owe a lot to you for your contributions in this area. I think as far as Gavi is concerned, the data speaks for itself, because we just showed slides from the Lancet paper which showed the heavy interplay of immunization with tackling AMR. And I want to thank the ambassadors of Malta and the ambassadors of Barbados for making sure that immunization is appropriately featured in the declaration. I think that was really very important, because there has been a policy disconnect between with respect to the recognition that immunization plays a very important role in tackling antimicrobial resistance. And I think the previous data that was presented of an analysis of the national AMR plans and how they featured immunization as a tool is evidence of that. And if I recall correctly, there were 108 national immunization, national AMR plans studied, and of those, only 18 mentioned immunization as a tool to tackle the problem. This goes a long way to show that there clearly is a policy disconnect with regards to the realization that immunization is a very important tool. I mean, the facts are very simple. Immunization will prevent certain bacterial infections and thereby reduce antibiotic use. It's common sense. And immunization will also prevent viral infections and thereby prevent antibiotic use. And some of you who work and live in the developed world might not relate to that. How can antibiotic use be relevant to viral infections? But the fact of the matter is that that's rampant in the countries that we come from. We come from health systems that are mixed, where the public system is underfunded, the private sector is totally unregulated, and antibiotics are effectively sold as chocolate would. There's mention of chocolate this afternoon. As chocolate is or Smarties are, and they're available over the counter. Everybody has access to antibiotics, and some of them are cheap because there are generic versions produced locally, and there are, for lack of a better expression, and excuse my saying so, quackery is rampant in these environments, and there are paramedics prescribing, and there are nurses prescribing, and there are unqualified health workers prescribing, and at the drop of a hat an antibiotic is used with absolutely no guidelines, and then there's this huge interplay of spurious and substandard medicines, which often doesn't merit an appropriate discussion in this whole discourse on AMR. So you have antibiotics with low levels of active pharmaceutical ingredients. There are lots of spurious drugs on the market. There's a rampant, excessive, unnecessary, and I would go as far as saying criminal use of antibiotics. And that contributes to, and for a whole host of viral infections, you have mothers and quacks and unqualified healthcare providers using these drugs indiscriminately. It's hugely contributing to the problem. And one of the most effective levers that we have is immunization. Back in 2000, we had 4 vaccines. Going forward into our sixth cycle, into a 6th strategy cycle, which is called Gavi 6.0, for which we are fundraising as we speak, we will have 24 antigens. There are 8 of them that are relevant to preventing the infections that lead to the excessive use of antibiotics, and you showed that we saw that up on the slide. So there's a huge interrelationship. You see, problems in countries don't come with labels that correspond to our vertical, programmatic and technical interests. And a lot of the solution to these problems are cross-cutting to some of the tools that we have. And immunization is one of the most effective tools that you have in the fight against antimicrobial resistance, which is why I think it is in our joint interest to see the Gavi fully replenished and fully funded for a 6th strategy cycle, which spans from 2026 to 2030. That's also a timeline where the SDGs will come to fruition. And our ask for the world is $9 billion. And we're going to significantly accelerate our work. Over the last 24 years, Gavi vaccinated 1 billion children. And going forward, we are going to do that in half the time. So, so all of you sitting here who are AMR champions are actually champions for Gavi as well, champions for immunization. And if you want to be equipped with tools, slides, data, presentations, my email is Sanyanish, that's snishtar@gavi.org. Please just reach out to me and ask me for any talking points, data, information that you might want, because we have a shared goal, and by working together we can really exploit a very important synergy.
No, that's great. And since you brought up replenishment, which I was going to bring up anyway, I think AMR would be an important part of that story for replenishment, because as you heard from, again, Prime Minister Motley, this is a good example of a global public good. Everyone is connected at the hip when it comes to the effectiveness of antibiotics. So just to press on before I turn to Sarah, it has to be a little more strategic, right? So how are we going to place AMR at the center of this replenishment, or at least one of the centers of replenishment, given that overall childhood diseases are coming down in terms of trends? So that can be part of the story for the next Gavi replenishment. But you've got the political declaration explicitly calls out Gavi, and everyone here is a supporter of public health, and certainly AMR, and certainly of vaccines as well. How can we position this better?
I think by stating that 8 of our vaccines are directly related to reducing antibiotic use, and that's directly proportional to what you're trying to achieve. For instance, we talk about the role of Gavi with respect to climate change. Well, half of the vaccines are in portfolio are relevant to the climate change agenda. We don't have to come up with a fancy strategy to demonstrate that. So I think the argument for our joint mission, for the synergy that we must exploit is very straightforward.
Okay. So I'll turn now to Dr. Sarah Dupre. So infection prevention and control. This is a challenge in both rich and poor countries. And unlike vaccines, and to some extent unlike WASH, is not really funded. There's a lot of knowledge gaps, the weakest of our prevention messages, but with greater hospitalizations, which is a good thing. People can afford to go into a hospital, but they're going into places where there are lots of infections. What can we do about this? And the US contributes a lot through multiple mechanisms to prevent infections, but what can you do on infection prevention?
So first, I just want to also express my appreciation for your leadership in this. I remember being here 8 years ago at this event, and I was reflecting today that while we haven't come as far as we would have wanted, in no small part because there was a global pandemic, a viral pandemic where there was a lot of misuse of antibiotics, I think that the declaration really does highlight the importance of IPC, and this is a real priority for the USG. CDC, for example, has recently educated 20,000 healthcare providers around the world about the importance of this. And I think the bottom line is we know what it is we need to do. It's really a question of having the political leadership and the funding in order to do it. Those are always going to be vexing problems, but the answer to what to do is not a secret. It's not a known unknown.
Right, and certainly we might need to set up a new mechanism for things like infection prevention, especially in healthcare facilities that we haven't done much about. But the U.S. already makes these investments in global wash immunization and IPC to some extent, but certainly immunization, certainly through Gavi. How can the U.S. leverage these better to tackle AMR? Again, I think it's a mistake to have AMR be the sort of standalone issue. It has to be dealt with from other domains and not just on its own. What can we be doing better to make sure that there's an attention in terms of tracking and making sure that AMR is a central part of that story?
I think that's right. It can't be seen in a silo, right? I mean, on the one hand, you want to highlight the issue itself of AMR, but at the end of the day, it's really about the ability to provide healthcare. Because without it, I mean, we can all do the talking point. Without effective antibiotics, we just go backwards in time to a time where we didn't have the kind of healthcare that we have today. So I think telling that story is really important as we think about leveraging the investments in basic healthcare, that it's all of a piece, as opposed to siloing it out as a specific thing you have to do. I think the other thing we must never forget about is the importance of data. We've heard a lot about that today. But making sure that providers understand that the interventions that they're making, the simple interventions, hand washing, immunization, what the effect is on patient outcomes. You have to really clearly make that link in order for providers to understand why all of this is important. That doesn't have to be specific to AMR. That can be, something that you do for any of the interventions that we have that providers provide. Mm-hmm.
So one of the things we found in this Lancet series was that AMR is going to be a major barrier to achieving the Sustainable Development Goals, particularly on newborn survival. And we will need new vaccines. We need new vaccines against Klebsiella, for instance, which is probably the biggest killer associated with newborn sepsis. How can we improve the innovation ecosystem so that companies are incentivized to invest in these vaccines with the understanding that these could then be deployed widely for tackling newborn sepsis?
So currently we don't have vaccines against the hospital-acquired infections of the category you referred to. And clearly what we experience here is what we should label as a market failure, because the commercial sector does not have an incentive to invest in R&D in these areas because the volumes clearly do not make it commercially viable for them. And this is the same phenomena we see in neglected diseases. We've seen in the neglected diseases of poverty also. There wasn't R&D in those areas, and hence certain catalytic mechanisms needed to come into play. And these market failures actually play out in every sector. For instance, if you were running a government and if you had privatized the distribution of electricity to the private sector, and the private sector, it was viable for the private sector to take electricity to big towns, but then there were smaller villages where the private sector would not take electricity, and the government would have to intervene, and there would be comparable examples from every sector. So coming back to the question you asked, clearly we have to either tackle this issue through the injection of public resources, catalytic resources, or have innovative instruments such as advanced market commitments, such as rewards for investors to come forward with solutions. And in the vaccine sector, the ecosystem is so structured that Gavi does, of course, the market shaping and the procurement and ensuring access to vaccines. But then there's another sister institution called CEPI, which provides the catalytic resources to bolster R&D in these areas. And Gavi also plays a role through by forging advanced market commitments, by creating the pull incentives, and by shaping the market. Because when you signal through your vaccine investment strategy that you will invest, that you will actually, there actually will be an appetite to procure this vaccine in bulk, effectively it shapes the market. And it provides an incentive for the investor to invest in this area. So collectively, through the market shaping tool of Gavi, which manifests itself in the vaccine investment strategy every 5 years, and through the catalytic R&D efforts of CEPI, investments in these areas are made where there's a clear market failure for vaccines.
Okay. So I'll give the last question to Sarah. So we have a political declaration that hopefully will stay in the same shape before it's adopted on Thursday. How might it influence how the US would think about making global investments on AMR? It has not done so yet in a major way, except through existing channels, which is our prevention and these sorts of channels. But we certainly need to think of other ways. I mean, CDC does work in some countries, but not terribly well funded on AMR. USAID has some very small stuff, but again, nothing major. But we surely recognize that the threat there is going to be a threat here if we don't stop it there. How are we going to think about things differently after Thursday in terms of where US priorities should go? Whether they go or not is obviously many people decide that.
Right, and I'm cognizant of the time in the year we are, right? Yeah. I mean, I think it's an interesting question, and I think that there's an opportunity for this community to really help shape that, particularly, I mean, we will have a new government coming in January, however it is, and so for all of you, being able to use this declaration when we have a new government in the U.S. to educate the new policymakers that will be coming in about the importance of this as a global issue, and that the U.S. can't do it alone, and we need to do it all together. I think it will be an interesting opportunity. I don't think that. Again, I don't have a ready answer for what's going to happen, the very next day. As you know, it's a time of change here, so just have to wait and see.
Well, let's hope for good change. And on that note, I'd like to thank our two panelists for sharing their thoughts today. I'd like to now invite Dipali Patel from the AMR Action Fund to moderate the next panel, and I'd also like to invite Dr. Trevor Mundell, Dr. Tina Tan, and Dr. Mareka Windrux on the stage.
Great, thank you, Ramanan. So I think it's been an interesting series of discussions so far. We have, it seems like we have a variable political commitment problem, we have a communication and word choice problem, we have a prevention problem, and this panel is going to talk about innovation and access, where I think we have challenges as well. But I think we're actually quite lucky because we have a group of panelists here who are going to tell us how they're going to solve this problem. And so hopefully we will walk away with a sense of thinking more about solutions as well in this space. So I'm not going to speak too much about innovation and access in opening this, because I think you all understand, and it's the title of this entire event, that we are only going to solve any of our problems in global health by ensuring that we can sustainably access the right tools at the right time for the right people. But I'm going to start with you, Trevor, by saying that, I think when we think about AMR, we are thinking about having a toolbox of interventions that we need, and to be able to deploy them in appropriate ways and at the right time. So what does your toolbox for AMR look like? And in terms of what may not yet be in the toolbox or could be improved in the toolbox, how do you see technologies like AI helping with getting those tools into the toolbox?
Thanks, Dipali. Well, for me, innovation and access are opposite sides of the same coin. So maybe I can answer that by starting with access and backwards inducting to the toolbox. So the profile of a drug, you can call it the target product profile that people in development like to use, that terminology. For a drug that we can really ensure has broad access, would have a couple of elements to it. One is it would have a very high barrier to resistance developing so that people would tend to use it first line. Secondly, it would be incredibly safe because although pharmacovigilance is greatly improving in lower income countries, it's still not as uniform. So you can't just put a drug out there and have any safety issues that might occur. And then most importantly, it needs to be extremely cheap. So, how are we going to get these properties? These are extremely high barriers to the development of a new compound. If you put them out there, in the markets and to companies, they would shudder to think that they have to meet all of those elements. You already mentioned, I think, one of the exciting set of tools that is being deployed now that might address a number of these elements and could be a kind of horizontal toolbox is artificial intelligence. And we are seeing this being deployed now with huge enthusiasm in drug discovery. I would say maybe there's a lot of hype around the current notions that we've solved all the problems of drug discovery and we just need to let these agents run riot and they'll produce the drugs for us. We're not quite there. But I'm really confident that if you look at the drug discovery process, in 3 to 5 years' time, it will be completely changed from what it is now. It'll be changed in terms of the time it takes to develop a drug. It'll be changed in terms of the types of actors and parties, stakeholders that can actually participate. And, so we're going to look at this drug discovery process in this tremendous era of change. And, I'm putting that forward. The other tools, of course, that are allied with that, but that would be the main tool that I think will make a difference.
Great, thank you. So Tina, coming over to you, since we're talking about drug discovery, research and development, that requires financing and investment. And in the US, there have been significant investments in new antibiotics through, for example, agencies like BARDA. But how high are these investments in priority, and what might help with advocating for more investment in this space?
Thank you for that question. These investments garner bipartisan support year after year, and they're critical for innovation, but unfortunately they're not enough. Companies that have successfully brought us new antibiotics to market with the help of BARDA continue to face bankruptcy because the antibiotic market is really fundamentally broken. And when you think about the way that businesses work, normally the more you sell, the more that is used, the more money they make. But for antibiotics, it doesn't work that way. I mean, we use antibiotics to treat infections to which the organism is susceptible to, but you don't use it to treat like viral infections and other types of infections. And in the US, the bipartisan PASTEUR Act is the single most important thing that our government can do this year to transform antibiotic research and development and help meet the global goal of reducing AMR deaths by 10%. Everyone seems to support the PASTEUR Act, but Congress really isn't making it a high enough priority. And it really is incumbent upon all of us to help policymakers really understand the urgency and the threat of the AMR crisis and the need for immediate action.
Great, thanks. So speaking about the urgency of the crisis, I mean, when we look at the burden of resistant infections, we obviously see that it's increasing across many countries in the global north, but it is quite significant in the global south. And even more, I think, increasingly so. And innovation is obviously very relevant and important, but it's also important that patients can access these drugs.
People have access and new antibiotics are development, and this is developed, and that is really what the Pasteur Act wants to do. It really wants to help companies understand the importance of this and really help them develop new antibiotics, which we really need to have done. I mean, as you heard the Prime Minister say, you know, we are down to just a handful of companies that now work on antibiotic development, and that is a real issue.
Yeah, so absolutely. So Marika, moving to you and continuing in this theme of financing and thinking about access, you know, where the problems are the greatest. So there are funds at the Global Fund available for antibiotics. For example, patients with HIV/AIDS who face or are increasingly vulnerable to resistant infections you're able to procure antibiotics on their behalf. So with that, and maybe beyond even thinking about procurement, how is the Global Fund using its existing resources to tackle drug-resistant infections?
Thank you very much. And first of all, if you're working on infectious disease, and especially HIV, TB, malaria, there's really no way you cannot be concerned about resistance all the time. And we've seen it occur. We monitor, we do a lot of surveillance. We change regimens when there's new options available and WHO issues guidance. And over the years, I think collectively, we've managed to have a healthy pipeline and really sort of managing to combine access, affordability, and innovation in a way I think that's quite interesting and has lessons learned. But also beyond HTM specifically, we do see that severe bacterial infections are a leading cause for people living with HIV. So we also have to look at what can we do for the broader AMR agenda, not just specifically for HIV, TB, and malaria. We have this catalog of health commodities, drugs, and other commodities that countries can use to procure, either from their own allocation or from domestic resources. There are antibiotics on the list. For some strange reasons, the uptake of antibiotics is very low. So I think that's absolutely something that we need to consider. I know there's lots of people asking the Global Fund whether the Global Fund could use its market shaping capacity and procurement capacity to also sort of give access to the next generation of antibiotics. Absolutely something we are willing to look at. But we first have to understand why is the current uptake so little. And then also I think some of the topics that also Tina mentioned, we need better diagnostics, we need better quality assurance, we need better stewardship, we need the regulation. So I think we're financing agencies, so we cannot do all of that. So it really requires all of us to come together.
Great. So it's interesting you were just talking about the low uptake, and I think this is also a sort of twin of access as well. And maybe Tina, coming back to you, because when we think about access challenges and access gaps, we do largely think about the Global South, but we have access challenges in countries, in high-income countries as well. So do you see that is a challenge in the US, for example? And what do you think is driving that?
It is an absolute challenge for the United States. We're seeing an increasing number of patients that we cannot safely and effectively treat with the existing antibiotics that we have. And that means that even though we've made enormous progress in medicine, where we can cure someone's cancer, we can basically transplant someone with an organ, we can give them a new joint, we can correct congenital heart disease, which would be fatal otherwise if it wasn't corrected. We can, change someone's heart valve that needs to be changed. But the problem is that all these individuals are at higher risk for developing infections, and many of these individuals succumb to their infections that they develop. And the other problem is that sometimes our only option to treat these patients are with toxic antibiotics that can cause serious liver, kidney, and bone marrow problems. I want to give you an example. I recently took care of a child who basically had traumatic brain injury, was involved in a severe car accident, and is paralyzed from the neck down, so has a trach, has been in and out of the hospital and in and out of inpatient rehab for the last 8 months, and basically presented back to us with acute on chronic respiratory failure, where he was basically having pus come out of his trach site. He had a severe pneumonia, and the problem is that the organism that was isolated from his pneumonia is a carbapenem-resistant Acinetobacter baumannii, which is one of the most antibiotic-resistant organisms that is seen here, not only in the US, but also globally, and is a growing antibiotic threat. It now accounts for about 30 to 50% of the Acinetobacter infections here in the US, and up to 60 to 90% of the Acinetobacter infections globally. So that is a major problem. The other thing that we're seeing is that resistant infections are increasingly becoming a problem among healthy people in the community. So more and more healthy children are being diagnosed with urinary tract infections that are resistant to oral antibiotic agents. So there are no oral agents that you can use to treat them. These kids end up in the hospital for 5 to 7 to 10 days to receive IV antibiotic therapy. This happens in women where they get urinary tract infections. It happens in pregnant women, and the problem is in pregnant women is that there's always the risk that they will transmit this resistant infection to the fetus that is in their womb. And then access to appropriate antibiotic therapy is a problem on multiple fronts. We know antibiotic stewardship programs help to ensure patients receive optimal treatment, but there are many healthcare facilities that don't have the resources that they need to fully implement a stewardship program. And the Pasteur Act would provide these resources to the hospitals and the long-term care facilities that most need them, and would make novel antimicrobials available to patients covered by federal programs such as Medicare and Medicaid at no cost. And this is incredibly important, as you know, as you can imagine, there are a growing number of individuals that are being covered by Medicare and Medicaid.
Thank you for that. And I think having those very specific examples, actually, it's very powerful to tell those stories. And I think we really need to do more of that as well, because that really drives the point home. I'm just going to close this panel with a question for Trevor and for Marika. I think this is a little bit of looking back and looking forward for the both of you. So, and I think, you know, a lot of us maybe first came to kind of thinking about drug resistance from the lens of TB. And the Gates Foundation was really obviously quite heavily involved with helping to fill that early stage pipeline for TB drugs. And so, you know, is there some way that we can replicate success like that for antibiotics? Is it similar, or is it quite different? And then Marika, for you, you know, kind of thinking about going forward, because again, I think a lot of this has to do with financing. You know, in the political declaration, there's mention of the Global Fund and the need for greater engagement in this space. And so what would you see as being needful for the Global Fund to kind of engage, knowing that you have all this experience, for example, with TB and others? So maybe I'll start with you, Trevor, and then over to Marika.
Dipali, what gives me hope that this problem can be solved, other than the fantastic activists who've been so persistent, like Dame Sally, like Ramanand, in this area, is really the TB story over the last 10 years. And if you think about organisms, TB is the quintessential resistance organism, which we don't even think about treating with monotherapy. And there have been a dearth of options of new drugs over there, because it also is not at all a commercial opportunity. So you're not going to get companies even that may participate in antibiotic development participating on TB of their own accord. But we were fortunate to be able to support a consortium called the TB Drug Accelerator, which involved academia, governmental institutions, and some companies that participated. And it was tough going because the idea about this is that each of those groups had a modest amount of resource or prepared to contribute a modest amount. Nobody had the full set of tools that they needed, but that we would get them to share their information and then we would support some additional tools. Now I can tell you at the beginning, at the outset, sharing that information across these entities was extremely problematic. But after a couple of years, when they began to trust each other, that happened. And I saw something change around somewhere between 2016 and 2018, so that the state of the TB portfolio now is completely different. And I'm pretty confident that over the next 5 to 6 years, we will see at least 2 new regimens, completely new regimens, and remember that is usually 3 to 4 drugs, that will be introduced for treatment of TB. And we've had a new regimen for drug-resistant TB, which has had a remarkable effect. So TB has got a lot of promise for us if we think about the models that worked over there. It is the quintessential problem of poverty, and it has, as I say, almost no commercial value, so it has those challenges. But I think if we think hard about what was effective in TB, we can bring some of that knowledge and evidence to bear on this even larger problem.
If I actually can build on that, because I think TB is a really good example of what we can do also for the broader AMR agenda. The Global Fund is the largest funder of MDR and XDR TB programs in the world. And I remember before I joined the Global Fund, I was a board member, when the Global Fund first started with the introduction of MDR drugs. There was a lot of anxiety that those drugs would be used for the wrong patients, in the wrong situation, in the wrong way. So initially, the Global Fund could only approve MDR TB drug programs. You have to be vetted by the Green Light Committee, which really built capacity at country level, really looked at, basically did the guidance and the stewardship that we don't have for the broader antibiotics now. And what really made a sea change was the gene experts and the better diagnostics. So for me, if we can learn some of those lessons for the broader, I think that's what we would need to really move. And I think there's really a lot to learn from the TB response. And also we're doing a lot in health system strengthening and pandemic preparedness. That is also highly relevant for AMR. The surveillance, the monitoring, the lab system strengthening, where we have invested a lot, training community health workers, and human resources for health. So there's also a lot of things we can do that's not maybe very specific, but really contributes.
Great, thank you. So before we close the panel, I'd like to invite 2 comments from 2 members of the audience, who I cannot see because the podium is in the way. But first, I'm going to ask Dr. Henry Skinner to come up and give some brief comments. He's the CEO of the AMR Action Fund, which I'm very familiar with.
Thank you, Dipali. And first, I'd like to thank the organizers of this evening's work and the panelists for all their really insightful remarks, and the speakers from earlier this evening, really hitting on all the key points around AMR, which is a huge holistic problem. I'm first a microbiologist, and while I'm CEO of the AMR Action Fund, I spent my career around AMR and trying to develop solutions to it. And listening to the discussion this evening, I keep coming back to one question in my mind as we look to where the fund invests in clinical stage new antimicrobials primarily. And that is, does the R&D landscape address the critical problems that we face? And I think the answer to that is no. It's certainly not broad enough, but it's also not properly directed. As we think about what we need globally and where the patients are and where the focus of the small, highly innovative companies are, they're not thinking of the problem as holistically as they should. They're not thinking of it, as Trevor said, how do we get the cost of goods down where these therapeutics can be accessible in principle to the broadest population. And if a small company is looking to the north and saying, we're going to develop the drug for the US and for Europe and a few wealthy countries, it can be impossible, even with everything done right, to make this accessible to the rest of the world. And so as we think about some of the solutions that are being proposed, pollen incentives like the Pasteur Act and other means of bringing industry and academia into alignment with what our needs are, we really need to think about these pollen incentives to be wisely designed so that they actually incentivize the greatest possible good by doing things like adding an incentive, making it wise to make a low cost of goods, to make it thermostable, to make it oral where it can be accessible broadly, to have low resistance potential, etc. So as I think about the opportunity this week, and really I think, and again, thank you to the organizers for such a robust start and really building for me the excitement of what's to come this week. Really look forward to that, and let's keep this alignment as we think about how we actually bring good to the world.
Great. Thank you, Henry. And then finally, I'd also like to ask James Anderson to come up. James is the Executive Director for Global Health from IFPMA.
Thank you very much. It's both good and bad to be talking at this point in the event, but I'm really pleased and would also like to thank the organizers. So I think it's good because we've heard, the problems are clear, they're very well understood, but the solutions are also clear. And we've heard them. We know what needs to be done. And thanks to the work of Francois, Vanessa, and the others, we have in the declaration a framework that will enable us to move that forward, I genuinely believe. We know that the companies that are developing new antibiotics are mostly then going bankrupt, right? Even those that actually succeed. Mm-hmm. That's clear. We know that then the researchers who have the experience of doing that work then go and work in other areas of research. That's the problem that's clear. We've heard from several already that the solution is things like the Pasteur Act. Those things are being done already in some countries. The UK has been doing it and taking it forward successfully. It works, it can work. Let's do it. When it comes to access, we've also heard very clearly the challenge. It's a good problem that we have that most of these antibiotics are needed in very small amounts in most countries around the world. It would be a bad thing if we needed lots of these last line treatments, right? So, but that does mean it makes it even harder to figure out how to get them to the patients that need them. So, hearing, for example, that the Global Fund can be coming in to help play that role, we believe is one of the few things that could make the difference in terms of pooling the demand, demonstrating what's actually needed, and getting it together. So, both in terms of innovation and access, it is recognized, it is in the declaration, so this is a very important step forward, and thanks very much for having me here as well.
Thanks, James. And thank you, Marika, Tina, and Trevor as well. This has been an excellent discussion. And I'd like to invite up now Apurva, His Excellency Jean Kaseya, and Dr. Hanan Balki, who I think everyone in this room also knows in this space very well. Thank you.
How are you?
Hello.
Nice to see you.
Nice to see you too. And actually, we have been speaking quite a bit lately. So let's jump right in. I'm hoping this panel will get some very practical answers about what can be done to actually achieve these targets. So Dr. Kaseya, I'll start with you, since we have been speaking a lot about Mpox. And I know that it's been consuming so much of your attention that Africa CDC canceled the public health conference that was supposed to happen in November. So given that, how do you keep AMR at the top of the list? And I think you have 90 seconds to give me an answer, but I would like you to name the top 2, 3, if you can manage it, things that you will do to keep AMR on the list of priorities.
Thank you. If you are looking for a face of someone who is in trouble, now you have the face of someone who is in trouble. I'm really in trouble. Let me tell you why we are in trouble. You know, in July, I had a call with my friend Chris Murray. I said, just give me some projections in terms of AMR, because we are preparing this summit, and I wanted to know what we can do and what could be the evidence that we can have. He gave me a long list of things, and I took only 3 lessons. The first one was we can have a projection of 7.9 million deaths related to AMR from 2025 to 2050. The second one, he said, you will see from the previous period, there will be a decrease on children under 5. The third one, he said, Northern Africa will have more cases, AMR, than other regions. That one was in July, before the increase of Mpox. Today, I consider Mpox as the major driver of AMR. I was in one of the countries affected last week. I saw a young person using antibiotics for more than 45 days, every day, admitted. I went to another country. I saw that sex workers, due to this stigma, they start to use antibiotics as prevention against Mpox. But when they are using antibiotics against Mpox, mostly it's falsified antibiotics. It means we are giving a route for AMR with this Mpox to be another, more than what we have today, another issue. And if you go back to the evidence that Chris provided, I think you have to review that. Because today, more than 70% are young people, less than 15 years old, even 38% under 5 years old. And you'll see, because Mpox is mostly in Central Africa, Western Africa, I'm not so sure that it will be less than the Northern Africa. It means we are changing now.
I understand the problem. I think we've all been hearing about the problem. I would really like to hear what you think can be done on a very practical level. What 2 or 3 things will you advise the ministers that you talk to try and do?
What must be done is first to recognize, and we are talking about it, One Health is the approach for us to stop not only Mpox, but to fight also AMR. Because, you know, in Africa our communities are living with the wildlife. And if you fly somewhere in one of the rural areas, they will say, please wait, we go to the forest to bring food for you. And I think bringing colleagues, putting in place this strong One Health approach will help. Second, it's about access to antibiotics. Because in Africa today, people are mostly dying due to lack of antibiotics. And if they have this antibiotic, it's falsified antibiotics. We need to have access to antibiotics. And the third one is to strengthen surveillance. And that one is critical for us.
Okay, well, you did get to 3. Dr. Baki, you had AMR efforts for the Eastern Mediterranean region, and I would like to hear, given everything that's going on in that region, how will you monitor for AMR resistance and combat it in that region, the countries that have the conflict and the instability, but also outside of it?
Thank you so much. It's great really to see the energy in the room is still holding up. I think it has to do with the image of the walls looking like Hershey's bars to me, so it's keeping me optimistic. I think for those who know the Eastern Mediterranean region, I'm dealing with 750 million people with 22 countries, with 40%, 42% of all the humanitarian of the world. So the disasters that we're facing in the Eastern Mediterranean region, 7 of them are in the African continent, but we have 2 of the biggest issues. We have Sudan with 10 million displaced, and we have the escalation in Gaza and now in southern Lebanon is what's going on. So the challenges are actually immense. But the issues that I wanted to raise here for tonight is that this investment that we're trying to do and the declarations that are coming out are really important. And as I was leading for 5 years the AMR division in HQ Geneva, now being on the ground, which is, I have to say, it's very exciting, challenging. But we need to understand that the efforts that need to come in leaving nobody behind is another total ball game in the Eastern Mediterranean region. The displaced populations, the destruct infrastructure, the running sewage that I saw when I was in Gaza, the thousands of people that are now moved into Chad with no healthcare facilities. We talk about WASH, we talk about access. There are huge challenges. That resistance will be emerging from the Eastern Mediterranean region in the conflict zones that will affect all of the efforts. So I would like to just maybe use my voice a little bit to say that we do really need to find some peace solutions, and then we need to start focusing on how we're going to provide sustainable healthcare systems to be able to address what everybody said in the past 2 hours, from access, and I would like to maybe address that in the next question or so. But there needs to be an understanding that this is one global community. What's happening in the Eastern Mediterranean region will affect the rest of the globe. Bugs know no borders.
And is there a way that you are already monitoring for AMR in that region?
Yes, the monitoring is challenging because you need very sophisticated diagnostics to be able to measure the impact. But I can tell you from some of the patients who left Gaza, for example, over 80% of them are already carrying multi-drug resistance. We are trying to work with our member states to be able to strengthen surveillance data and diagnostics. Now we go back to the diagnostic part. We would love for the industry to develop bedside diagnostic tools so that we can measure it. It's a very difficult, I'm a clinician, infectious disease by training, so this is my bread and butter. It's very difficult to make diagnoses for understanding this specific topic of resistant bacteria. You're not talking about HIV or TB or malaria. You're talking about over 20, 30, 40, 50 different bugs. Only bacteria, but there's another parasites and viruses. So it's very complex to measure. The WHO is working with the member states to strengthen their laboratory diagnostics and capacity. Imagine doing that in the 40% displaced population of the world that we have to do. So I hope that you understand the complexity of this, because again, I know that we have very thick skin as WHO, we take a lot of punches, but we cannot be solely responsible for this. And that's why we work very much with our partners. We work with the African CDC, GCC, TDC, CDC, and globally we work with a lot of partners. It's important to be innovative in the diagnostics because that's your specific question. We will do everything we can to make sure that that measurement and that reporting takes place so that the industries in therapeutics and vaccines can then build on that knowledge to be able to prevent stronger tools when it comes to therapeutics and vaccines. So it's a very much linked ecosystem.
Dr. Kasaya, she just brought up diagnostics, and in your report, Africa CDC's report, there was a startling statistic that in the African labs that you surveyed, that only 1% were actually carrying out AMR analyses. So how would you go about changing that? And then I have a part 2 to that, which is also from your report, that 1 in 3 hospitals lacks clean running water. So given everything that we've been saying here about infection prevention, how would you tackle that?
Yes, when we say to strengthen surveillance, we cannot do that without lab. And you saw in the report, only 1.3% of labs that we assessed in 2023 from 14 countries were able to perform the bacteriology testing. How do you want to conduct a strong AMR program if you have only 1.3% of labs? This is a major issue. And that one, we are seeing that also with Mpox. I was in a country where the testing rate was 18%, 1/8. How do you want to say that you can perform a surveillance program. It means strengthening the lab component is part of the surveillance mechanism that we are putting in place, and we cannot move on without that. And also, there is this increased vaccine hesitancy. And for us to ensure that we are fighting AMR, we need to go to what I call the basics, IPC, vaccination, Even I like what a lady said. I see you, you are there. Dr. Gada, this is my first meeting. You said even raising awareness cannot contribute to change behaviors. I quote you well, I think. It means, in addition to what we are talking about, we need to raise awareness, but we need also to put in place other actions that can help to change behaviors. If we do that, we can succeed. If we don't do that, as I said when I started, I'm in trouble.
Okay. Since you brought up vaccination, we've been talking about that too, the interplay of vaccination and AMR, and in the region that you are responsible for, there's also a lot of vaccine hesitancy, mistrust, and we've seen polio come back. And so how do you tackle both of those at the same time? And then you wanted to talk about access. I'd like to hear about that as well.
Thank you. So the hesitancy issue, I think it's global, and each community needs to deal with it based on the knowledge and the understanding of what is making them hesitant. What are their extreme worries? So in some communities, they're worried about a conspiracy theory, that these vaccines are to control birth, for example. In some others, they just have a misunderstanding of the benefit of the vaccine. So I think those programs, the public health infrastructure and the personnel that are in these countries and in these communities need to work creatively to identify how to tackle them. On the polio, specifically, you're asking about the polio. Of course, my region not only has significant number of countries with the vaccine-derived polio, but we have the last 2 countries that actually we need to eradicate wild polio from. The heroic work that has been done during Gaza for those days of tranquility to be able to do the polio immunization just re-emphasized again the need to support the infrastructure and hygiene and wash, because it's extremely devastating to see after 25 years of no polio, now the children of Gaza have cases of vaccine-derived polio. The teams on the ground are doing everything they can, and I think this is a global response that is really focused in the Gaza Strip. And I would like to give credit, even though us, UNICEF, UNRWA, and the Palestinian Ministry of Health are given a lot of credit for this, but it's really the Palestinian and Gazan health workers on the ground. Over 470 health workers are conducting the polio immunization program. We owe them a lot for being able to do the first round. The second round will start sometimes mid-October, and until that is completed and until we continue to bring back the immunization program in the Gaza Strip and to all of the displaced populations, then we are in trouble. If I can have just 1 minute on the access. So on the access flagship for the Eastern Mediterranean region, I have identified that the regional office needs to be complementary to our work in headquarters, which is norms and standards and guidelines, and to support in the operationalization of implementation of health in our 22 member states. And one of the flagship programs is on access, so that we can identify through the flagship, through the chain of this specific flagship, the bottlenecks that are owned by the WHO, unplug them, such as the national regulatory authorities, digitalization of the warehouses, identifying the major gaps, mapping the pharmaceutical industry within the region, and then to work with our partners to ensure that we're filling the gaps, unblocking the bottlenecks, and making sure that we're basing that on burden of disease, gaps in reaching our SDGs, so that we can try to be innovative in leaving nobody behind when it comes to access of healthcare and healthcare commodities.
Thank you both for that.
Thank you.
I'd like to invite Leslie Ogilvie, Director of Secretariat for the Global AMR R&D Hub.
Thank you, Purva, and also thanks to the panelists for such insightful discussions. It's really been a pleasure and honour to listen to these discussions this evening. I think we all know the high-level meeting brings crucial attention to AMR and calls for international cooperation and also multi-sectoral collaboration. But we know the real test will be transferring these commitments into actual long-lasting and actionable solutions. This is especially important in light of the many world challenges that we're facing at the moment. Our panel has highlighted a few very eloquently here, and we need to think about this as we move forward. How do we break down these bottlenecks? I'm definitely an optimist, but when we think about this journey from commitment to implementation, I think there has to be a healthy dose of realism. Strong governance, adequate and sustainable financing, robust evidence, and also the political will is very necessary. But we also know we need the technical know-how, that know-how on the ground to actually do the implementation of these solutions. So I come from an organisation that supports decision-making in AMR R&D called the Global AMR R&D Hub. I know it's a bit of a mouthful. And at the Hub, we really understand the sort of importance of data and evidence to help prioritise and allocate these resources and funds which are very limited, we know, globally. I think at the moment, as our panellists have highlighted, the current evidence is showing us that we need to prevent infections in the first place. This is the first point of call. Equally vital is to make sure that we have equitable access globally to those life-saving drugs and other products addressing AMR. At the same time, we really need to have a much stronger and more sustainable ecosystem and pipeline of therapeutics, vaccines, and diagnostics, and also make sure that they're accessible to the people that need them most and they're used with care. I think CARB-X, GARP, AMR Action Fund are really doing their bit to bolster these pipelines, but more is needed and faster. I'm nearly finished. The independent panel on evidence for action against AMR holds great potential to guide that transition from commitment to action, building on knowledge, building on the initiatives that already exist, and also the great stakeholder community that we have. I hope that we can do this faster, better, with much more specificity and much more accountability. Thank you.
Ramanan, going to deliver some closing remarks.
Thank you.
Thank you so much. Thanks.
Cecilia, you wanted to make a comment from FIND? Okay, why don't you come up and make a brief comment, and then we'll close up, and then we'll head to drinks. So Cecilia from FIND.
Thank you. I'm sorry for being between you and your glass of wine. I'm going to be very brief. I think that I cannot agree more with all what have been said by all the speakers. There are a few things I think are really takeaway homes, and one is on the AMR messaging and what we want people to know. But then the second one, as Gada has been quoted 2 times already, is like, why do we want people to know about AMR? What is exactly that we are expecting from that knowledge? And there is something also that was mentioned from the Global Fund and the experience from TB, right? Few drugs for TB are available. The only way they can be used in a safe way is with diagnostics. So I think for all of us, new antibiotics are great if we know how to use them, where to use them, and I'm calling for diagnostics as well, vaccines and WASH. Like without WASH, without vaccines, without diagnostics, we're not going to be able to use those antibiotics in a safe manner. Thank you.
So, ladies and gentlemen, with that, we come to the close of the formal talk, but we can continue with the informal talk over drinks. I think, as you've heard, I think the 2 changes in tone that we're hearing over the last 8 years is, first, much more important recognition that AMR is important. We can't, it's not just a problem which can be sidelined. It's really coming into its own now as being recognized. And the second is that we can actually crack this problem. We have all the tools. You heard it here today. So I don't think it needs to be seen as a complex problem, a difficult problem. I think we need to go forward as a community to show that this is a problem that can be solved, it can be tackled, and I hope that when we come back here in 2029, that we will have a very different kind of story to talk about, and one of success at having really cracked this problem. So with that, thank you all. You've been a wonderful audience, and have a great rest of the week, and see you at drinks in the other room. Thank you.